Hello, everyone. Welcome to today's live broadcast, Inventing Active Surveillance version 2.0. I'm Brenda Kelly Kim of LabRoots, and I'll be your moderator for today's event. Today's webcast is presented by LabRoots.com, the leading social media site for science professionals. For more information, please visit us at www.labroots.com. Before we start, there are a few instructions. We want to hear from you during this interactive broadcast, so please ask questions or leave us a comment. Answers are welcome too. You can do this by hitting the green Q&A button at the lower left of the presentation window and typing in your comments and questions. We'll try to get to as many as we can, and we'll follow up with you if we don't have time today. Want a better look? You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you can't hear or see this presentation properly, please let us know by clicking on the support button on the top right or use the Q&A button. We'll make sure we try to resolve any issues. This presentation has been approved for continuing educational credits. If you want to obtain the credits, please click on the Get Your Free CME CE Credits button located in the lower left of your screen. This will take you to a page listing all of our speakers and presentations. Please select the CE CME button under the presentation and follow the instructions to claim your certificate. Now let's get right to today's presenter. We are proud to welcome Dr. Eric Klein, MD. He's the chairman of the Gleason Urological and Kidney Institute and a staff member in the Taussig Cancer Institute at Cleveland Clinic. His clinical interests are cancers of the prostate, testes, and kidney. For several years, including the current edition, Dr. Klein is listed in Best Doctors in America. For more information about Dr. Klein, please click on his name to learn more about his background. I'll now turn it over to Dr. Klein for his presentation.
Thank you, and good afternoon, everybody. Thank you for joining us. The subtitle of my talk is Prostate Cancer in the Era of Precision Medicine. We have evolved to the point where in almost every clinical decision we make in prostate cancer, we have molecular data available to us to guide our decisions. And precision medicine is defined as making a specific management decision or treatment decision or choice of drug based on the individual molecular characteristics of an individual's tumor. And today I'm going to be talking about the use of the precision medicine approach in what might be called active surveillance version 2.0 or next generation active surveillance. And excuse me, I'm having a little difficulty advancing my slides here. Here we go. Let me start with my disclosures. I work with many of the companies that have worked in this space developing genomic and gene expression-based tests for active surveillance. It's important that everybody know that neither I nor anybody at the Cleveland Clinic have any financial interest in any of these companies or anything that I'm going to talk about. So let's talk about active surveillance. Let me say that active surveillance has been gaining traction in the United States in the last several years. And so I'll start with a disclaimer. It's my belief that most men with very low risk, or almost all men with very low risk, and most men with low risk disease, and even some men with intermediate risk prostate cancer are appropriately and safely managed with active surveillance. And if you agree with that, and if you already put most or all of your patients with these characteristics on surveillance, then you're not going to need the tools that I'm talking about. So my message today is for those of you who are reluctant to put your patients on surveillance because of your fears over really predicting what the underlying tumor biology is for each patient and understanding how to follow them. And so those fears are widespread. There are two recent publications that look at the penetrance of active surveillance in the management of very low and low risk disease. One is from the Capture Registry, which is a conglomerate of academic and some sophisticated private practice institutions. And if you look on the very right-hand side of the slide in the most recent years that were measured, 2010 through 2013, and you look at the solid dot, you can see that the use of active surveillance has increased in this population to about 40%, which is absolutely terrific. The problem is that the individuals who are part of the Capture Registry are highly motivated to do this. And if you look at a broader database covering only patients with very low risk cancer, those who are ideally managed by surveillance, and you look at a broader database, the National Cancer Database, you can see that nationally fewer than 10% of all patients who should go on surveillance actually go on surveillance. And so what both of these slides tell us is that there is significant room for improvement in terms of the use of active surveillance. And we have to understand why practitioners don't put more people on surveillance. And I believe it's mostly fundamental anxiety over not being able to predict an individual's biologic potential at the time of diagnosis. So let's talk about what active surveillance version 1.0 looks like. I'll talk about two recent publications, one from Toronto and one from Baltimore, that show us that active surveillance is safe for most patients, but highlight the role of precision medicine. So in improving it and making it next generation. So this is the current paradigm. When we see a patient who has an initial biopsy and they're categorized as very low, lower, intermediate risk disease, we look at their comorbidities and life expectancy and patient desire. And up until recently, we generally have reevaluated those patients to be sure that the initial biopsy didn't miss higher grade cancer that would disqualify them from surveillance. And again, until the last year or two, I would say, at least in our practice, that meant everybody had a second biopsy soon after the first, because we know that initial biopsy has a significant sampling error. And if the patient were a candidate for surveillance, then in version 1.0, he would be reevaluated periodically for a change in risk categorization. So we would see him every 6 months and do a digital rectal exam and PSA. We, generally speaking, have followed the Hopkins paradigm and biopsied everybody once a year. And if someone's cancer was treading water, as I tell them, still remained low grade and low volume Gleason 6, they stayed on surveillance. But if there were progression in the broadest sense of the term to higher grade cancer, where they moved from very low to low risk, or they moved from low to intermediate risk, or their PSA were going up, or the patient decided that he no longer wanted to undergo the biopsies or was worried, then we would intervene. That's what surveillance 1.0 looks like. We have two great series now that tell us that this is safe to do for most patients. This is data from Laurie Klaas's series in Toronto, demonstrating that roughly for 1,000 patients who were put on surveillance, that the death rate due to prostate cancer at 15 years was only 6%. And you can see out of 1,000 patients, roughly, there were 15 deaths and 13 developed metastatic disease. So overall, you could say that for every 1,000 patients who went on surveillance using his relatively loose criteria, which included some men with grade 3+4s, and where the triggers for biopsy were based, at least in part at the beginning, on PSA velocity, and where everybody wasn't biopsied every year, the patients did pretty well. And in fact, if you were to look at the data in his series, you were 9 times more likely to die of something other than prostate cancer if you went on surveillance than you were of prostate cancer. But I have some concerns about that data that illustrate not that surveillance isn't a good idea for most patients, just that it isn't perfect. And that as we think about inventing next generation active surveillance, there's the opportunity to apply the precision medicine approach to improve this and get the decision right for every patient. So here's one of my concerns. Of the men who had intervention, and there were a little under 300, I think, who had intervention, half of them had biochemical failure after radiation or surgery at 15 years. Why is that a problem? You've all had this conversation with the patient, which is someone who's reluctant to go on surveillance, and you really think it's the right thing to do, and you're counseling them, and they say, "Are you certain? Can you look me in the eye? Are you certain that if my cancer gets a little worse in a few years that I can still be cured?" And in order to convince a patient for surveillance, we have to honestly answer that question, yes. Well, this data suggests that that, in fact, is not true. And it's not that these men with biochemical failure 15 years after treatment are going to die of prostate cancer, but some of them will go on to get secondary therapies like radiation therapy or hormones, and some will go on to develop metastasis. And again, all I'm suggesting is not that surveillance isn't good for these patients. It's just that we can do better, and we need to have better tools that allow us to qualify patients more accurately for surveillance at the beginning and to follow them to know when to pull the trigger while they're on surveillance. Some other cautions that I have. In both series, as I showed you, the number of patients who were followed for more than 10 to 15 years is actually quite small. The median follow-up in the Klotz series is only 6.5 years, and as I'll show you in the Hopkins series, it's only 5 years. So I think we need longer-term data. But let's do the math. If you were to take Laurie's data, for every 1,000 men, there were 15 deaths and 13 who developed metastasis. That means for every 10,000 who go on surveillance using his criteria and follow-up, there'd be 150 deaths and 130 who get metastasis. And for every 100,000, it's 1,500 and 1,300. And so if you think about this and project what we might do in the United States for the next 10 years, this is a very reasonable assumption. If we were to take all this data and say surveillance is the right thing for most patients, as a group of urologists in the United States, we're going to put 100,000 men a year for the next 10 years on surveillance. So that's 1 million men. Well, what happens if we do that? There are 15,000 deaths and 13,000 men who get metastatic disease. And while it's true that they would have avoided the acute treatment-related side effects, in my experience, most patients would rather go through those side effects than avoid the risk of death or metastasis. And so that's an important conversation that you have to have with each patient. Each will make their own decision. But again, it illustrates to me that there's an opportunity to use genomic testing to better identify these patients who might run into trouble and either disqualify them from surveillance from the beginning and treat them, or to detect when their cancer progresses while they're on surveillance and intervene before they run into a problem. And so this is the Hopkins data, which used much stricter criteria for entry. These were only very low and low-risk patients, no intermediate risk patients. And you can see roughly, again, it's a little over 1,000 patients. In the blue line, you were far more likely to die of other causes than prostate cancer if you went on surveillance using this. And here are the data for each of the risk categories, very low risk and low risk. But if you look at the bullet point showing overall, there were 5 men out of 1,300 who developed metastatic disease and only 2 who died of prostate cancer. And that's really quite convincing that most men with very low and low risk disease ought to go on surveillance. And again, what stands out is that most men in the United States, despite this great data showing it's safe, don't go on surveillance. So the tools I'm going to talk about, again, are to help practitioners push patients toward the right thing, which is surveillance. Now, there was a cost in the Hopkins series for achieving these results. And here's the cost: annual biopsy in all of these patients. And what I've learned in my practice in active surveillance is that annual biopsy is costly. It occasionally causes significant problems, which we'll talk about in a minute. And it isn't necessary in every patient. I really believe that as we have these tools now that really reveal what the biology of the tumor is, that we can tell who's progressing while they're on surveillance and who isn't, and know when to pull the trigger in a far better fashion than we know now. And that's going to be part of what I call active surveillance version 2.0, which I'll show you at the end of my talk. So here are the cautions from the Hopkins series. Again, the median follow-up was only 5 years, and you can see only 26 patients were followed for 15 years. The biochemical failure rate after intervention was only 8% as compared to 50% in the Toronto series. And again, that relates to the fact that there were stricter selection criteria in the Hopkins series, and patients were followed far more closely with biopsy. And overall, 2 deaths and 5 metastases. So let's do the math here, and the numbers look far better with stricter criteria and stricter follow-up. For 10,000 patients, it's only 20 men who die and 50 who get metastatic disease. Per 100,000, it's 200 to 500. And again, if you put those 100,000 men a year on surveillance for 10 years, 1 million men, it's 2,000 and 5,000. Now, those are great data. Again, I find them very convincing that most men with very low or low-risk disease should go on surveillance, but it's not perfect, and we need to be able to do better. And so the question comes then, as you look at this data, is active surveillance good or bad? Well, it's good if you're not one of those men who develop metastasis or die while on surveillance. And on a population basis, the numbers are so favorable that if you were designing, for example, the healthcare system on managing prostate cancer for a whole province in Canada or for a state or for a country, you would say surveillance is the way to go. But I believe that on an individual basis, there's room for improvement in case selection. And our goal ought to be not to get it right for most patients, but to get it right for every patient. And that's where precision medicine tools come in. And I believe that these tools can refine individual biologic risk that can help us at all the steps during surveillance that I showed before. And there are some other limitations of surveillance. How often do we really need to rebiopsy patients? I have many patients that I biopsied on a yearly basis where the biopsy is repeatedly negative, or it again only shows 1 core of low-grade Gleason 6 cancer, and I always wonder if putting the patient through that was really necessary. The problems with biopsy, this is a recent report from Australia that looked at the national sample of biopsies over a 5-year period, 34,000 biopsies, and you can see there was almost a 2% biopsy-related readmission rate at a cost of about US $7,000 per case, and there was 1 death. And so it suggests to me that as we invent active surveillance 2.0 and think carefully about this, that we can use these new tools to do fewer biopsies, and that is certainly something that patients will like, but it also is safer and less costly. Do all patients need to be followed at the same intensity? If you have a patient who starts out with low-volume Gleason 6 disease and has a very favorable biologic score, a genomic score, a gene expression score, my suggestion is that that patient doesn't need to be followed with nearly the same intensity as someone, let's say, who has higher volume Gleason 6 disease, who's more likely to harbor Gleason 7 disease that was missed by biopsy, and that's someone who could be one of those who is destined to progress and develop metastasis or die, and that we ought not see those patients at the same interval. The first patient could be followed less closely, and the latter patient needs to be followed more closely. And then I think that we don't really know when to pull the trigger, and I'll show you a couple of examples in a minute on how to, or rather what the dilemma is there. But I think we could use these tools to decide when to intervene and prevent that. So, and I will again emphasize to you, not that I think this is worrisome data in the sense that we shouldn't do surveillance, but we need to keep in the back of our mind that when we promise a patient that they go on surveillance, that we can still cure them if they progress. We're not 100% there, depending upon the criteria. It could be as high as 50% failure rate, or it could be as low as 8% for those with the most minimal biologically indolent tumors, at the cost of having a biopsy every year while you're being followed. So let's talk about two typical clinical scenarios that will illustrate what the role of these precision medicine tools are. These are real patients from my practice. A healthy 60-year-old man, based on Social Security life expectancy, has a long life expectancy, and he has very low risk disease. And if we were to do a radical prostatectomy on him, theoretically, he could have favorable pathology, and this is what he's likely to have: Gleason 6 disease that's organ confined, or low volume Gleason 3+4 that's organ confined, and we would say that we overtreated him. But we know from experience that about 20% of patients who meet these very low risk or Epstein criteria actually have what we consider to be adverse pathology: dominant pattern 4 disease, with or without extraprostatic extension, or Gleason's 8 disease or worse. And currently, our ability to predict whether this patient, if he were to undergo a prostatectomy, were to fall into the green box as opposed to the purple or pink box on an individual basis is quite limited. The best we can do, and I'll show you the data a little bit later, is to predict that he has an 80% chance of being in the green box and having favorable pathology, and a 20% chance of having adverse pathology. Wouldn't it be nice to have a biologic tool that increases the accuracy of our prediction that the patient has favorable or unfavorable pathology? That's what these new tools can do. And so this gentleman, just for illustrative purposes, happened to have a prostatectomy, and it turned out that he was in the pink box. And as I have given this talk to many urologists across the country, and I asked the question, if you knew, before you operated on this patient, if you knew that he was in the pink box with adverse pathology, would you offer this patient active surveillance? And in almost 100% of cases, urologists say no, they wouldn't. So if we knew for sure the individual had adverse pathology, we wouldn't put him on surveillance. If he were in the green box, we certainly would offer it to him, and then depending upon the patient's age and comorbidities and his desire, he would be a great candidate for surveillance. Here's another scenario where these new precision medicine tools can help us. Again, a younger patient, healthy, real patient, also has very low-risk disease, and he goes on surveillance. And a year after his initial biopsy, which shows 1 of 12 cores with Gleason 6 disease, he now has Gleason's 3+4 disease in 1 of 12 cores. And so the question is, that we always scratch our head about, is this undersampling? Was that grade 7 cancer there previously and just missed by the initial biopsy? Is this true progression? Or is this variability in pathologic interpretation? All of us have had the experience where we have 2 different pathologists, both of whom are excellent clinicians, look at a biopsy, and one calls it Gleason 6 and one calls it Gleason 7. One of the problems is with surveillance is that we can't distinguish between these 3 possibilities for these patients. And I hope to demonstrate to you how using a biologic tool can prevent that. So here's the real issue here. You've all seen this sort of slide. This is a cross-section whole mount of a radical prostatectomy specimen. And we know that there are multiple tumors in most prostates. And we know that there's variability or heterogeneity in grade. And we know that the biopsy often only hits the low-grade disease. And so we're trying to develop ways of looking at the entire prostate, the biology of the entire prostate, even though we only have low-grade disease. And so the two questions that arise are, how well does Gleason's grade predict true biologic potential? That's one issue, and I believe that there's a subset of grade 6 tumors that are pure grade 6 that do have some biologic potential, probably on the order of 5 to 10% of them. And then how accurately does the biopsy capture the biology of the whole prostate? Those are the issues that we have. And so I'm going to talk now about the development of Oncotype DX made by Genomic Health. And there are some other products on the market, Prolaris and ProMark, which I don't have any personal experience with, although we did some of the validation studies with ProMark. And I don't have a particular favorite. I'm going to talk about Oncotype DX because we helped develop it at the Cleveland Clinic, because it's the one that I use and that I know best, and because I think it has some advantages to the others. And so in order to address the question of how can you capture the biology of the whole prostate just based on a biopsy that shows low-grade cancer, we did an initial experiment where we took 500 radical prostatectomy specimens, one of which you see here, in whom we had 15 to 20-year follow-up on these patients, and we microdissected the low-grade pattern 3 and the high-grade pattern 4 tumor. And we asked the question, if you sample the right genes on these biopsies, looking at RNA expression, gene expression, if you sample the right genes, could you find genes that predict who got metastatic disease and who died? And the answer to that question was yes. And then we asked the question, if you looked at the right genes, did it matter whether you sampled them in the low-grade or the high-grade tumor? And surprisingly, the answer was no. If you look at the right genes, it doesn't matter whether you look only at the low-grade tumor. You can still predict what happens to the patient. And that was the experiment that we did. And so how can that be? This is a little bit of biology now, which I won't dwell on, but I want to explain this because it's important that everybody understand this. We've all been taught appropriately that every individual clone of a tumor, every individual cell almost, or nest of cells, has its own genetic biology, and that's absolutely true. They all have their own private mutations that you see in that structure on the very right, which looks like a tree with branches. But what we've learned in the recent years is that there also are some truncal mutations or truncal changes in gene expression that are shared in common by all the tumor clones. And so if you measure the right biology, if you measure the truncal mutations or the truncal gene expression, you can capture a common underlying biology that is reflective of everything that's going on in the prostate. And another way to think about this is this. If you think about the difference between a smart car and a Tesla, they both have very different potentials. One's sexy and fun to drive, one goes fast, one doesn't go fast, it doesn't go so far. The interior appointments are nicer in one or the other. But you know intuitively by looking at them that they're both cars. How do you know that? They both have wheels, they both have steering wheels, they both have passenger seats and driver's seats, and they both have engines. And so those are the truncal mutations or the truncal gene expressions that characterize the essence of those cars. Well, if you think back to tumors again, all the tumors that we have looked at, and I believe this is true for most prostate cancer, perhaps not in 100% of cases, but in a substantial majority, that they have a common underlying biology that can be measured by biopsying even just the low-grade cancer. That's what our data shows. So that brings us back to the whole-mount prostatectomy specimen where we're looking at our problem, and the way Oncotype DX was described is the biopsy only samples the low-grade tumor, but because we're looking at the truncal common underlying biology, we can measure the biology of the whole prostate. And you can immediately see how this intuitively can help us select patients for active surveillance, because if you biopsy the patient and you only have low-grade tumor, but it has molecular characteristics of a higher-grade tumor, that's someone who's going to be in that pink box, someone who has adverse pathology, and if they're young and healthy and have a long life expectancy, they probably shouldn't go on active surveillance. So this is the promise of genomic approaches. And this is a hypothetical construct that suggests that within each risk category, very low, low, and intermediate risk category, there's actually a spread of risk. It's not that everybody in each category has the same risk. You have some patients who have favorable biology, illustrated by the green dots, and some patients who have unfavorable biology, illustrated by the red dots within each risk category. And so genomics, in the way that I just talked about, can separate this man with low-risk disease who actually has very favorable biology from this man who also has only low-risk disease based on PSA grade and stage, but actually has unfavorable biology. And again, if they're young and healthy, the man on the left with in the green dot should be a good candidate for surveillance, and perhaps the man on the right shouldn't be. So I mentioned the other available markers on the market, and although they predict other things, the ones that are useful for active surveillance, that they all are biopsy-based predictors for adverse pathology. And by that I mean what's in the pink box. Dominant pattern 4 disease. We all know that patients who have dominant pattern 4 disease, even if they have a prostatectomy or radiation therapy, are at higher risk of disease recurrence and death. It's not that those patients aren't cured in large measure, they are, but those are the patients who are at higher risk. And the same is true for extraprostatic extension or grade 8 disease. All of these tools that are on the market help us more accurately predict who's in this purple box and who has adverse pathology and therefore adverse biology and who aren't good candidates for surveillance. So I mentioned this earlier. The question arises now, how good are we predicting who's in the green box with favorable pathology and who's in the pink box with unfavorable pathology currently? Well, the answer is not as good as we think. We're not 100% accurate, and that's the goal of precision medicine, is to get the decision right for every patient at the start of surveillance and all throughout all the processes of surveillance. And so this is a large prostatectomy from Hopkins that was published about 2 years ago that shows us how accurate or inaccurate we are. So you can see for very low-risk disease, NCCN very low-risk disease, or Epstein criteria, we only accurately predict who's in the green box 80% of the time. And so you can have very low-risk disease and you have a 1 in 5 chance of having adverse pathology and therefore not a good candidate for surveillance if you're young and healthy. And for low-risk disease, we're only accurate about 70% of the time. And I estimate, although it's not from this data, that for intermediate-risk disease, we're only accurate about 50 to 60% of the time. So these tools can improve on these individual predictions that increase our accuracy for each of these. And I'll illustrate some case examples from my practice later in the talk to show you how to use these and how they improve accuracy. These are the genes that are in Oncotype DX prostate. There are 12 cancer-related genes and 5 reference genes. It's not important that you know what they are. It is important that you recognize that they measure a broad biology, 4 different pathways that drive cancer. And what did these genes predict for? Well, if you measure them, if you measure their expression on prostatectomy specimens, they predict for metastasis and death. More importantly, and in an experiment that I haven't described to you, when you measure them on biopsy, whether it has pattern 3 or pattern 4 on the biopsy, it predicts for adverse pathology. It predicts who's in that purple box who shouldn't go on surveillance if they're young and healthy. It predicts for dominant pattern 4 disease or disease outside the prostate as defined by extraprostatic extension, seminal vesicle invasion, or lymph node metastasis. And again, if you had a patient in your office who had a biopsy that shows only low-volume Gleason 6 disease, but you knew that they had dominant pattern 4 disease or one of these other adverse features, you wouldn't put them on surveillance. That's what these tools can help. So after we did our biopsy study, we went to some collaborators at the University of California, San Francisco, Pete Carroll and Matt Cooperberg, and asked them to repeat the experiment. They took 400 men who'd had biopsy and prostatectomy in San Francisco, and we asked them to test how well Oncotype DX predicted the presence of these adverse pathologic features. And what I'll show you is a remarkable spread of scores among each category. So these are patients who meet Epstein criteria, NCCN very low risk, and you can see the scatter in the scores there. You can see that not everybody clusters in the middle. Not everybody with very low risk disease actually, when you measure the biology using Oncotype DX, has the same risk of adverse pathology. And you can see way out to the right that there are 2 green dots, men who had very low-risk disease but who actually biologically have a high likelihood of having worrisome biology and probably aren't good candidates for surveillance. And the same thing was true for patients with low-risk disease, and interestingly, it was true for patients who had a certain kind of intermediate-risk disease, low-volume Gleason 3+4 on biopsy. What this data suggests to me is that that hypothetical construct I showed you a few slides ago with the yellow arrows and the green dots and the red dots is actually real. It's not a hypothetical construct. Within each of these clinical risk categories, there's a real spread of biologic risk, and we can exploit this information in a way that helps us make more informed decisions. So if you have very low or low-risk disease and you have a low likelihood of having adverse pathology, all the dots that are to the middle and to the left, good candidate for surveillance. And if you have very low or low-risk disease and you're young and healthy and have 20 years ahead of you or 25 years ahead of you and you're one of the dots that are out on the right, you're probably not a good candidate for surveillance. But look, with the intermediate risk, there's a big spread, and there are a lot of men with intermediate risk disease who have a very low risk, based on the GPS score that you see on the x-axis, of having really biologically aggressive cancer. And this suggests to me, I think it's revealing, that there are many men with Gleason's 3+4 disease, low volume, who have very favorable biology and are good candidates for surveillance. And that would, of course, be older men who may have some comorbidities. I'm not sure I would recommend that for a 50-year-old with intermediate risk disease. Nonetheless, it identifies some patients who have criteria that are usually used to exclude patients from surveillance, that when you look at the biology, actually, we should be more inclusive. And so I'm going to show you the same data from the San Francisco validation study in a slightly different way. Each dot here represents one patient from these 400 in clinical categories, very low risk, and intermediate risk disease. And here's what happens when you add the biologic information. I'm sorry, I went back on the slide. Let me move forward here. And so here's what happens. You add Oncotype DX, and you can see that a substantial number of patients with low-risk disease biologically actually have very low-risk disease. That should increase the patient's confidence and your confidence that those are great candidates for surveillance and that you're not missing worrisome cancer that you wouldn't want to follow. And there's a smaller percentage of patients with low-risk disease that you might have otherwise considered for surveillance who actually have intermediate risk disease. If they're young and have a long life expectancy, probably not good candidates for surveillance. If they're older and have some comorbidities, you still might consider them for surveillance. There are a couple of patients with very low-risk disease, not nearly as many, who change risk categorization, and I showed you those two green dots earlier. Those are men who are not good candidates for surveillance, in my view. And there are even some men with intermediate risk disease who actually biologically have low-risk disease, who, again, depending upon their individual circumstances, might therefore be a good candidate for surveillance. So if you just consider men with low-risk disease, all those yellow dots are men in your office that look the same to you. They all have 3 cores of Gleason 6 cancer, PSAs of 5, and normal-feeling prostates, and you don't know how to distinguish one from the other. Well, the biologic tool that we now have can separate these patients into those with biologically very low-risk disease, great candidates for surveillance, low-risk disease, probably a good candidate for surveillance, where intermediate risk disease, again, depending upon their age and comorbidities, maybe not such a good candidate for surveillance. And that improves our ability to select patients beyond grade stage in PSA. It doesn't replace grade stage in PSA or clinical judgment or comorbidities or age or life expectancy, but it adds to it and it allows us to make more accurate predictions. So when we started this work, our goal was to change behavior. I showed you that nationally, fewer than 10% of eligible patients are going on surveillance. Well, what's happened since these tools have been available on the market? There are 2 practice pattern studies that have been published now. One was primarily in LUGPA-type private practice groups, which showed when these practitioners started using Oncotype DX in this instance, that the percentage of patients who went on surveillance increased dramatically. And what was really remarkable, and I think highly appropriate, was that the number of patients who went on surveillance increased for each risk category, very low, low, and even intermediate risk disease. And I was pleased to see that because that was the goal of developing these tests to begin with, which is to increase the number of eligible patients on surveillance. And there was another prospective study that included mostly academic centers and a few private centers that showed the same thing, that the absolute increase in use of active surveillance was about 10%, which is a move in the right direction. So let me conclude my talk with a couple of case examples and then show you what I think active surveillance version 2.0 really ought to look like. I want to remind you, before I show you the case examples, of how accurate or inaccurate we are using grade stage and PSA to predict who is in that pink box with favorable pathology. Remember, these are patients newly diagnosed that had one biopsy that shows low-grade cancer, and you're trying to decide whether or not they're a candidate for surveillance. If we use just the information we have now without the biologic information, we get it right 80% of the time for very low-risk disease, 70% of the time for low-risk disease, and about 60% of the time for intermediate-risk disease. So again, these are all real cases. A young man, long life expectancy. He has very low-risk disease, so you see his biopsy, Gleason's 3+3, 1 out of 6 cores, 30%, 3 millimeters. Based on the information that's on the slide, he has an 80% chance of favorable pathology. There are a lot of urologists and many patients who think that that's not good enough, and they end up getting treated, and many of them, about 80% of them, will be overtreated. Well, here's his Oncotype score. If you look on the left where it says likelihood of favorable pathology, he actually has an 88% chance of favorable pathology. That's an absolute increase of 8% compared to what we would have predicted based on grade stage and PSA. And it's a relative increase of 10%. So to me, this makes our decision-making about 10% more accurate. And in my view, he's a great candidate for surveillance, and that's what he did. So let me compare two cases. This should be case 2A and 2B. And look at patient B first. He has low volume Gleason 6 disease. And look at patient A, about the same age, about the same PSA, and he has higher volume Gleason 6 disease. And when I show this to most urologists, most everybody says, yeah, we'd consider surveillance for patient B, but not for patient A because he has higher volume Gleason 6. Well, they both have low-risk disease, which would predict a 70% likelihood of being in the pink box of having favorable pathology. Well, here are their side-by-side Oncotype scores. Patient A actually moves from low to very low risk with a likelihood of favorable pathology that's actually about 81% instead of predicted 70%. And patient B, who had lower volume tumor, actually is in the intermediate risk category. He's one of those yellow dots who moved into the red zone that I showed you a couple slides ago. So patient A went on surveillance, and it's actually been on surveillance for 2 years now without sign of progression. Patient B actually went on to have a prostatectomy, and he had a grade 7 cancer with focal extraprostatic extension. Now, some people get upset when I show this and say, well, you would have picked up his progression on his next biopsy, and he might not have died or had a PSA recurrence, and that might be true. But I will, again, emphasize to you on a population basis, even using the strictest selection criteria and annual biopsies in the Hopkins series, 8% of patients who had intervention later were not cured. Here's the third case. This is a pretty dramatic case, a 75-year-old physician who came to see me after he'd finally been biopsied. You can see his characteristics there. Look at his biopsy. Less than 1 millimeter of Gleason 3+4 disease in a 75-year-old. So his actuarial life expectancy is just about 10 years. The likelihood of him dying from a Gleason 3+4 low volume cancer is virtually 0. And he meets intermediate risk criteria, and I really counseled him and tried to push him towards surveillance. And he insisted that he wanted to be treated, and I said, let's do an Oncotype DX, and we'll see who's right. And he was right. Here's his Oncotype DX, which predicted a high likelihood, 50% chance of having adverse pathology, and here's his prostatectomy, Gleason's 8 with extraprostatic extension. Really remarkable that the biology was able to be correctly assessed based on less than 1 millimeter of tumor on the biopsy, and that really shows how powerful this technology is. And he's done well after his prostatectomy. So many of you are probably wondering, well, why not just re-biopsy everybody a second time? Why do we need this fancy, expensive genomic test? I think genomic testing is better because no patient who's had one biopsy wants to have another one. A second biopsy is subject to the same sampling error. It doesn't get it right. All biopsies have a risk of serious infection and even death. And more importantly, and I think this is underappreciated, genomics are objective. Okay, we all have great pathologists, but the pathologists only can read the information that's in front of them, and there's a fair amount of variability in Gleason scoring. Biology is not dependent upon pathologic expertise, and so if we use these tests widely to determine eligibility for men before they start surveillance, you could more often get it right because you have an objective read of the biology that's not dependent on the local expertise of your pathologist. And what about MR? Let me confess my bias and say that we are fans of MR. We use it all the time now. But if you think about what MR does compared to what a genomic test does, when you're considering putting a patient on surveillance, I think a genomic test is a better choice. And here's why. MR makes biopsy better, but it's not perfect. So MR doesn't see all tumors. Some of the data that I'm showing there on the right, there are 3 published theories now that show that MR misses about 15% of grade 7 or higher tumors. And the practice patterns in the U.S., the most grade 7 tumors get treated in the U.S. and not followed. And so MR doesn't see all tumors. So if you rely only on MR, you're going to be wrong 15% of the time. MR increases the likelihood of finding a Gleason 7 cancer, but it can't tell you if it needs to be treated. And I think I've shown you pretty convincing data from the biopsy series, and this is from our prostatectomy series, these Kaplan-Meier curves that show in the green line that there are about 15% of men with intermediate risk disease who actually had very favorable biology and can go on surveillance. Wouldn't it be wonderful if we could reduce overtreatment of those men by using genomic tests? MR has no long-term follow-up data in the surveillance population. That will change with time, but at present it doesn't. And the data that I showed you on our prostatectomy series, we have 20-year follow-up on the ability of genomics to predict metastasis or death. And finally, and importantly, just like biopsy, genomics are objective and not operator dependent. There are lots of private practice urology groups in the country who don't have MR fusion biopsy available because they can't afford the equipment and they don't have the radiologic expertise. And I can tell you from personal experience, it takes some practice. There's a learning curve to doing this correctly. Genomics doesn't need that. All you need is the biopsy that has the cancer on it, and you can get an objective read of what the biology of the patient is. So what does all this mean? What does active surveillance 2.0 look like? Well, here's the current paradigm, which I showed early in the talk. Let me show you how active surveillance 2.0 might happen with a genomic-based paradigm. At the beginning, there's no change. We still see patients who have low-risk disease or very low-risk disease or intermediate-risk disease come to the office and say, what should I do? And we still need to consider their comorbidities and life expectancy and their desire and so forth. But when we want to consider whether or not they're really a candidate for surveillance, we can reduce the burden of determining eligibility by substituting a biomarker for a second biopsy. That allows an objective read of the biology. And also, if you use, for example, Oncotype DX or ProMark can tell you about the biology of the entire prostate. We also can improve patient selection. So we all have had patients who have very low-risk disease who are reluctant to go on surveillance because they're worried that their cancer will progress and metastasize before they can be cured. If they have a favorable score, we can increase their confidence and our confidence that surveillance is safe. On the flip side, there are occasional patients who have low-risk disease, even very low-risk disease, who want to go on surveillance, but whose biology really is more worrisome than they should. And in those patients, we can increase acceptance both for ourselves and the patients that treatment is warranted and that the side effects are warranted. And I have used these tests in that manner several times. We also, I believe, can change the intensity of monitoring. I don't have data to support this yet, but it makes sense, and I throw it out there as a testable hypothesis. If you have a patient who decides to go on surveillance and has a very favorable score, he probably doesn't need to be as monitored as intensely as someone with an unfavorable score who, despite that, decides to go on surveillance. So again, the difference between a patient with 1 core of Gleason 6 with 1 millimeter of cancer versus 5 cores of Gleason 6 with a couple millimeters of cancer. I believe biologically those are different patients. We should pay more attention to the latter patient than the former one, and we can use these sorts of tools to even identify those who have even lower volume Gleason 6 disease who need to be followed more intensely and in whom we can intervene. And then finally, we can do something that's called serial biologic monitoring. Again, I don't have data on this, but it is being studied prospectively, where we can develop a way of deciding when to pull the trigger. So you think back to that clinical scenario I showed you, case number 2, where the man went from Gleason 6, 1 out of 12 cores, went on surveillance, and a year later has 1 core of Gleason 3 plus 4. Is that true biologic progression? Well, we don't have the tools to know that now, and most of those patients end up getting treated, although I suspect many of them are overtreated. We can use these tools on a serial basis, measuring their biology on their initial biopsy and then on their subsequent biopsy 2 or 3 years later to help decide when to pull the trigger. So let me conclude with this perspective. We're on the threshold of a new genomic-based precision medicine paradigm for prostate cancer that I am quite excited about. These biomarkers add to but don't replace standard predictors of outcome. This is very important. Grade stage and PSA still matter. Age of the patient, comorbidities, life expectancy still matter. What the patient wants to do still matters. But these biomarkers allow us, if we use them, to make more accurate decisions and to give both ourselves and patients information that allow more informed decisions. These are first-generation assays that improve decision-making now and will get better with additional iterations. And the analogy I use here is if you look at your cell phone and what it can accomplish compared to your very first desktop computer, there's magnitudes of difference. And with the genomic technology that's evolving 10 years from now, I think we'll be in the same place. And we ought to develop a competency with the first tools that we have now to get used to them I do think that the first generation tools make us better decision makers. I also firmly believe that additional iterations are going to make these better. And then finally, and most importantly, getting a clinical decision right the first time is always the most cost-effective approach. People worry about what the cost of these are, and I would say to you that getting the decision right for the patient, whether it's surveillance, whether it's immediate treatment, whether it's knowing when to pull the trigger, is always the most cost-effective approach. So I leave you with a wonderful picture of Cleveland on the 4th of July. I thank you for your attention and very pleased to take questions.
Thank you, Dr. Klein, for bringing that important information to us. Great presentation. I just want to remind our audience before we get started with any questions that here's how they can reach us today. Questions can be sent via the green Q&A button at the lower left of the presentation window, and we do want to get to as many questions as we can, so I want to just give our audience a second to find the button and submit their questions for Dr. Klein. Very important information presented here today, and there's a lot to take in. Okay, I'm just going to keep an eye on our queue. All righty then. I see that we don't have any questions today, so I would again like to thank Dr. Klein for his time and also thank Lab Groups for bringing this presentation to us. Dr. Klein, do you have any further comments, final comments?
You know, I was just reflecting on this 4th of July picture there and how exciting that can be. That's how excited I am about all of this new technology and our improved ability to manage patients.
Very true, very true. Today's webcast, I want to let our audience know, will be available for on-demand viewing through March 2016. And they'll receive an email from us alerting when it's available on demand and posted on LabRoots.com. We hope that you will forward this announcement to any colleagues who weren't able to join in today. Thank you again for logging in and participating in today's broadcast. We'll see you next time.